be over a cardiac assessment, so we can combine the last few chapters with the one we went over on Tuesday. So it's going to be the normal stuff, just like you find in your book and that we've gone over since you've been in the EMT class. Safety is important, and make sure you do your first 5 here. So on the general impression in the primary survey, make sure we're asking about those life threats and see what their appearance is like. Not just, normal skin stuff and things like that, but does it seem like they're working hard to breathe? And what's their position? And then we have to make sure we look at their circulation. Are they cyanotic? Are they diaphoretic? That sort of thing. Can really help you out. So make sure we don't need any C-spine protection on these people, that they haven't fallen recently and suffered trauma, been in a car wreck in the past few days, that sort of stuff. So these things help us with determining our mental status, you know, our AVPU, make sure they're responsive and their airways open. So if that happens, you go to breathing, and if that's good, you go to circulation, all this kind of stuff. So with kids, I mean, do they have a cry? A silent cry in a kid's a pretty bad sign, that sort of thing. It's going to be an airway obstruction. So if they're unresponsive, don't forget about how to do a jaw thrust. Look for your signs of airway compromise, your cyanosis, all the things for your foreign bodies that you would look for, things like stridor. Make sure that they have a clear airway. You don't hear any gurgling sounds, so you can suction them if you do. So make sure that they're not having any sort of obstruction to their breathing. And then don't forget about your OPAs. Those are important on people that need them. So make sure their breathing is adequate. And if it's inadequate, we really need to help them out. So chest rising fall is important because it ensures that they have the adequate tidal volume to actually meet the needs of their body and maintain homeostasis. Make sure they're not using accessory muscles in their neck and their chest. Are they belly breathing if they're a kid? This sort of stuff. And then be ready to move to the BVM and that sort of stuff and CPAP. So make sure you check the rate that they're breathing at. This is kind of important. I mean, think about sepsis patients, one of your criteria. So you need to know that. And then especially with kids, look for that nasal flaring. We talked about COPD on Tuesday, so you know what pursed lip stuff is. So you can also record if you hear sounds before you even put a stethoscope up to the patient. You can usually hear stridor without one. There are audible wheezes, and those people are usually pretty bad. The gurgling, if you need to actually suction them. Your people with low blood sugar are generally going to be snoring. It means they can't protect their airway. So not a good sign. So see if it's clear and equal, but listen for your crackles, your pulmonary congestion kind of stuff. Give them the O2 that they need if they need it. And if it's absent, just go to the BVM. So we got to make sure that we control our bleeding and that we check for uh, their pulse. Is it strong enough? Is it normal? Is it there at all? Do they have a radial? Maybe their radial is absent, but the carotid isn't. That sort of thing. And then don't forget we talked about in the assessment section about this disability. It's going to be a more in depth in your AVPU. And make sure you can establish a baseline. Are these people normally ANO4 or what? So make sure that whatever environment they're in, they can actually maintain adequate body heat. They're not too hot, they're not too cold, that sort of thing. And make your transport decision. Don't forget you got to reassess frequently, so you can't just sit behind these patients all the time and not do anything. Sample PRT is very important, like we've discussed before. It's going to really help you out in your differentials here. And watch for your signs and symptoms. Just because someone is having difficulty breathing doesn't mean it's respiratory. It could be cardiac as well. It could be several things. So dyspnea is just this uncomfortable, awareness of your breathing. The same way palpitations is uh, an uncomfortable awareness of your heart beating. Maybe it's too fast or slow, that sort of thing. So you got to watch out for things like headache, fever, and chills. That could be caused by hypertension. They could be septic. Chest pain is very important to get those PRST stuff in. And then, of course, the edema in the lower extremities, throat tightness from stridor. If you have a sort of whistling sound with inspiration in the upper airway, then it's an obstruction and it's either caused by anaphylaxis or a foreign body. And if it's with expiration, like they have wheezes, that's going to be lower in the airway. You know, do they have difficulty breathing when they walk a couple steps? Are they okay when they're sitting down? Did it come on all of a sudden, or have they had a history of this? Now, as far as kids go, because adults usually don't show what tetralogy of Fallot, uh, if it can be relieved by squatting the dyspnea, that's a pretty good sign they have a missed tetralogy here. It's also a sign of failing heart. I mean, you know this from CHF. And then you got to watch out for orthopnea, which is can they actually lie down flat and breathe, or do they have to be sitting up like their CHF patients? And we discussed PND on Tuesday. Now we should talk about coughs. It's kind of important. We have to ask, is there actually anything they're coughing up? Is there sputum production? What color is it? Is there any blood in it? How long has it been going on? Like if there's blood, that's going to be a complication where they're just coughing way too hard, way too much. Now, if they actually have some syncope, this can be pretty bad. You kind of have to learn what the danger feints are. We've gone over, if it's on the toilet and that sort of stuff, maybe they vagal down, that sort of stuff. But you have to be aware that a lot of the instances of syncope is going to be cardiac related. So you got to watch out for their heart rhythms. Is it too fast? Is it too slow? You got to kind of make good clinical decisions here. So be sure you know how active this person is in real life. How long have they been out? If it's syncope, did they fall? Did they hit themselves? Has there been actually any involuntary movement that we would think of as like seizure activity? So, how long after they actually woke up and their family was with them that they weren't actually their normal ANO4 cells? And then watch out for those medical bracelets. Look for that. Make sure you get their medications and allergies. It's going to be really important. Look especially for diabetes and seizures, previous heart problems. Maybe they just have a cardiologist. Ask them about it. So, as far as palpitations go, make sure you get a description of how the patient defines it. There are a lot of causes, and we went over several of them in the case study there. And there's a lot of other symptoms too. So, there might be diaphoretic, nauseous, chest pain, even radiation on these people. So, they're going to be constantly fatigued. They're working pretty hard. So, it's going to impair their cardiac output, but it's going to feel rather vague. So watch out for your onset and duration, and ask about those associated symptoms, even if the patient doesn't know that they're, relevant to the situation. Make sure you get your allergies, please. So on the medications, be sure that they actually are taking them, and then try and learn your common cardiac medications. Things like your beta blockers and your calcium channel blockers. This thing is going to treat atrial fibrillation and high blood pressure, and then things like Lasix, the diuretics. So whenever you have all these medications, you can just look them up on your phone. Eventually, you'll learn what they're for. Make sure you ask about recreational drugs and a drug like an ED drug like Viagra, especially Viagra because it's an older one. There's a few more side effects here. You need to ask what they used before. It does dilate your vasculature here, so they may have passed out because of that too. By the way, And then anything that's non-prescription, like if they feel like they've been sick for the last few days and they keep popping aspirins in there, we need to know about it. How many of those have you taken? How often? So their past medical history. If someone has a doctor that they see normally, that's usually a better sign. And then the history of stuff that would be cardiac, heart failure, high blood pressure, irregular heartbeats, atrial fibrillation. Any time that they've had chest pain before in the past, is this the same? Is it different? And then what do you think about it? So things like history of strokes and diabetes, kidney disease, because these things kind of lend themselves to predisposing people to have heart problems. So it gives them a lot of risk factors there, especially if they've been in the hospital before, maybe even been on a breathing tube, or they've been hospitalized for chest pain so they can watch them. Last oral intake, if you have time, you can ask them about it. But the events preceding is far more important. Were they at rest? Were they just watching TV? So it could be the difference between stable and unstable angina. So make sure you get all your vital signs in a pulse ox. So if we're going to do something, we need to know why, even if you're a paramedic. So all these things are reasons why paramedics would actually start a 12 lead, and there's a whole lot of them. Uh, so we need to make sure that it's actually is it a dysrhythmia? Do we think it's cardiac? Is there upper abdominal pain, especially in older women? History of strokes because they have clotting problems, that sort of thing. So watch out for cardiogenic shock. Be ready to go fast at the drop of a hat here. If they have a low blood pressure and you and chest pain, it's generally going to be something that's going to be related to a heart attack. But if they have a high blood pressure with chest pain, it could be all sorts of stuff like a stroke. You got to watch out for those aortic dissections and heart failures. They're trying to compensate for this low blood pressure, but they're just making the condition they have worse. So look for signs of low cardiac output. Are they very pale? Are they mottled? So the skin condition can help you with that. Capillary refill, especially in the young and the old. And then if they've had recent infections, if they use IV drugs. So when you're watching them, see, are they restless? They can't even sit still because of the pain. Do they have fletched skin? Maybe this is sepsis. Watch out for your tachycardias and your increased respiratory rate, your high BPs. So always keep an index of suspicion for these things. Now, as far as JVD goes, to actually see it, you got to make sure that these people are sitting up at least 45 degrees and that they actually have the JVD there. So you have to look and make sure you make a mental note to always look on these people that have chest pain or it could be cardiac because it is a sign of the activity of the right side of your heart. So as far as the chest hit, they got a scar for like a previous coronary artery bypass, a CABG. Have you had a heart surgery before? Did they need to repair a valve? Do you have the barrel chest pink puffer COPD thing? How's the respiratory effort? Are there any retractions? Things we talked about before. So watch out for your triple A's. You know the sort of pulsating mass in the abdomen. Don't feel it too hard. If you feel it once, you don't have to go back and look again. You might rupture it. And then watch for edema because this could be a long-term problem. So swelling in the lower extremities, it can actually happen in the back too. And you need to check for pitting here. So I usually like to press down right over their ankle bone here because it gives me something kind of firm to press against and see if that divot stays in there. That's usually worse edema. We've actually talked about nail clubbing in the last class period here. Here's another picture of it. You also need to watch out for things like nitro patches, which people do have. And then the bulge under the skin, which would be a pacemaker, so they do have a cardiac history. So when you're listening to breath sounds, I like to do just the apices and then the bases. That'll give you a good one. Be sure to note is it diminished, absent, present, that sort of stuff. Is there any adventitious sounds bronchi, wheezes. Are they actually having foamy blood tint sputum? And do we need to put those people on CPAP? So heart sounds are best heard in a quiet environment, so it's hard to really hear those in an ambulance. So the S1 and S2 is going to be normal. The first sound is going to be the low pitched lub sound. It's a kind of a dull sound, but the dub is typically higher pitched than the S1. If there's a third sound called an S3, that's normal in children and young adults. You don't have to worry about it. If it's there in some older individuals, you kind of got to watch out for CHF. So here's something else. This is kind of more old school, but you may see it somewhere. If they have high heart rates, you can actually give them carotid massage on both sides because it has those baroreceptors, which is going to cause them to institute the vagus nerve response. Their heart rate's going to slow. But if they actually have something called a bruit, which is a sound, a bruit, it's kind of a swishing sound. If you want to know what it sounds like next time you have a renal patient that actually has a fistula, just put your stethoscope up to it. It's just a swirling sound, like it's going over and over and tumbling on itself. It's because their carotid sinuses, or carotid arteries rather, are blocked. So it's the blood trying to get around them. These sort of people have really bad atherosclerosis. So be sure and feel their chest, any tenderness or crepitus. Look for those trauma signs. Make sure you palpate the abdomen looking for triple A's, looking for tenderness. It could be pancreatitis. It could be gallstone, that sort of thing. Now, as far as this goes, it's the pulses that you can actually take. If you actually look down here at E, that's the popliteal pulse. So you can't just take that on someone who's standing up normally. You actually have to lay them down prone. They have to bend their leg, and you have to get it on the correct side. So it's going to be the medial side, just beside that tendon there, if you actually feel it. And then as far as the posterior tibialis, it's going to be right there behind the ankle. That's picture G there. And then if you want to look on the top of the foot, usually just kind of pressing that area in between the first and second toes. You got to be kind of light to actually feel it. In cardiac arrest, you can feel the femoral, which is going to be picture D there. It's going to be right in that crease there, and it follows that along. So you know this, but look for rate, rhythm, strength, quality. Make sure both sides are equal. So make sure they actually don't have a pulse deficit, and they don't have this pulses alternans, which we talked about earlier on Tuesday. And we also refer to electrical alternans. This could be a side of tamponade. It's where they have one larger QRS wave, and the next one's going to be smaller, the next one's going to be larger. It alternates in the electrical strength. Now, the pulsus paradoxus, which we talked about before, the reason you actually would check for that is because it is a sign of a dissected thoracic aorta. So what you would do is when you're taking the pulse, just watch and see when they inhale, and then see if it feels remarkably different than when they actually exhale on the strength of their radial pulse. So your pulse pressure, which we've gone over, the normal is going to be something like 30 to 40, the difference between your systolic and diastolic. But if it's widened, it could be something like shock, or it could be a brain bleed. It usually gets far more narrow when it's tachycardia because the heart can't fill up with blood as fast as it's pumping. It's also narrow in cardiac tamponade, like I said, Beck's triad. So be sure and reassess en route to the facility. Check on their primary complaint, but make sure you look for other sorts of complaints they might have. Give them the medications they're going to need. Monitor the response to all your treatments, and then reassess breath sounds. Especially if you're giving them fluid, give them the 250 bolus and then reassess that. If you actually have ECG monitoring for an advance where you are, you need to do more than one. Look at it several times, make sure it hasn't changed. Get more vitals, and then compare it to what their baseline normal would be.